Happy to see you again. Today, we are going to learn about basic nursing care. We all nurses, we all know that how will give a basic nursing care to the patient. But in palliative care, most of the time, so we have seen many patients in home. When the patients in the hospital, we are there. We nurses, doctors, and other health professionals are there. We will take care of them well within the hospital. But when they back to their home, who will take care of them? So that is the point. So if we need to give a proper instructions or a proper training to the caregivers before discharge the patient from the hospital. So that is why we put this topic into this course. This is one of the major part in palliative care. So let me share my screen. So first, you have to learn the principles. The principles in caring for a bedridden patients. So what are the principles? If you give a proper care to the bedbound patient, we can able to prevent health-related complications. So what are the health-related complications? If you have seen a bedbound patient, just if you anytime if you have seen a patient, a bedbound patient, then you have to think about how to prevent a pressure sore. Okay, so that is the main thing from the nurse. So from the nursing point of view, you will think, okay, so what are the ways to prevent pressure sore? So that way we can able to prevent that kind of complications. Okay, so for a bedbound patient, bed sore is one of the major complications. So always you have to try to prevent for the pressure sore occurrence. And the next point is promote comfort. If you give a proper advice or guidance or proper training to the patient and the caregivers, definitely they feel comfort. And if you give a proper nursing care to the patient, definitely the patient feel more comfort. Okay, and then build confidence level. So again, as I mentioned earlier, if you give a proper training to the patient caregivers, so that we can able to build their confidence level. So then when they go back, they will be able to take care of a bedbound patient. So okay, if they are able to take care of bedbound patients, what happened? The patient, the bedbound patients not getting any healthcare complications like pressure sore or any other problems. Let's discuss one by one. And prevent isolation. So just think, when we discharge a patient for a bedbound patient, just think about a paraplegic patient. If you discharge from the hospital, when they go to their own home and they are not able to walk, okay, so they will be in the one room. Okay, that so nobody go there and take them out, and they are alone. They are feeling alone there. So if we give a proper home care or training, or just give a phone call to the patient and ask them how are you feeling today, or is there any problem, that kind of things discussion there, definitely they feel okay, someone's begin them to support them, they feel we can able to prevent that isolation level. And then improve call, definitely if you give this kind of training to the patient and the caregivers, if you give proper support to the patient, definitely we can able to improve the quality of life of the patient and their family. So these are the basic needs of a patient. For a normal person, these are the basic needs. But we all know how to take care of us. So if a bedbound patient, they are not they know these can be done, but they are not able to done. So that part within the hospital we will take care of them as nurses. So when they go back, the caregiver is the person to take care of them. So we need to train the caregivers. So oral care, skin care, eye care, ear, nose care, hair care, perineal care, nail care. So these are the basic needs of a patient. So let's discuss one by one. First, we will discuss about oral care. We all know that oral care is equal to overall health. If you give a proper oral care to the patients, definitely we can able to promote their comfort level. And the literature says 90% of systemic diseases are linked with oral health. Okay, if you are not giving proper oral care to the patient, definitely it will cause lot of problems. So we all know that mouth is an excellent incubator for growth of bacteria because the food particles are left in their mouth. So if you are not clean well, definitely this is the good medium for bacterial growth. And you have, for that, you have to maintain a hygienic practice and try to remove the food particles from the mouth. Through that, we can able to prevent bacterial growth. And you can able to keep the lip and mucosa soft, clean and intact. And then so as I mentioned earlier, we can able to comfort the comfort level, promote comfort level, and then improve. If you give proper oral care to the patient, definitely we can able to improve the nutritional status, and that way we can able to stimulate blood circulation and eliminate source of unpleasant odor and prevent dental caries. So these are the purpose of oral care. Coming to the oral problems, there are a lot of problems in oral cavity. So which few problems which we have seen in palliative care are: one, dry mouth and painful mouth, and halitosis, candidiasis, oral mucositis, alteration in taste. So these are the excessive salivation. These are the common oral problems which we have seen in palliative. So let's discuss one by one. Xerostomia. So xerostomia is dry mouth. So it look like this. Okay. If you have seen a bedbound patient, definitely you have to check the oral cavity whether the patient is having xerostomia, dry mouth or not. And the second one is candidiasis. So candidiasis is oral thrush. Okay. Candidiasis infection. If the patient is having oral candidiasis, like it could be extend to the esophagus too. At that time, the patient is not able to swallow properly. So you have to check. If the patient is complaining of dysphagia, you have to check whether the patient is having oral thrush or not. And the next thing is halitosis. Okay, sometimes they won't feel they are having halitosis. We can able to feel the patient is having halitosis. We need to treat the patient. And mucositis. Most of the after chemotherapy and radiotherapy, so the patients will get mucositis. So you have to check. And these are the main common problems. Next, we move on to the needs. So who needs mouth care? Eventually, we all needs mouth care, but few patients need mouth care more frequently. So let's see one by one. Terminally ill patient, unconscious patient, and the patient who are breathing through mouth, because and most of the unconscious patients they are breathe through mouth. So because of that, dry mouth can occur. So that patient need frequent mouth care. Postoperative patients and patient with infections and disease of mouth. Example, CA buccal mucosa. For recurrent infections in the oral cavity present, so you have to clean every 4 hourly. And patient is having nasogastric tube feeding. So these the patient is having nasogastric tube. You usually the caregivers not give proper attention to the oral cavity. So we have to give a special. We need to empower and educate the patient caregivers about the importance of oral cavity care. So coming to the assessment part. So we learned about what is the purpose of oral hygiene, and who needs palliative care, and what are the common problems of oral cavity. So these all things we already learned. Now we come to the assessment part. When we assess oral cavity, you have to check whether there is any cracked lips and dry or clotted tongue. Sorry, we have some technical issues. I'll come so. Okay, sorry. I hope my screen is visible to everyone. Uh, okay. You have to check whether there is any cracked lips or dry or clotted tongue, and white curd-like patches. If the patient is having any oral candidiasis, you look like some white curd-like patches. You have to check whether there is any candidiasis infection. Ulcers in the mouth, any ulcers in the mouth, any redness or bleeding, any pain in the mouth, you have to check the patient is having any pain. We already learned pain is a subjective symptom. Always you have to ask the patient whether they have pain or not. And dysphagia or change in taste of food. As I mentioned earlier, if they have a oral candidiasis infection, it could be extended to the esophagus too. So that time the patient is not able to swallow properly. So if they have complaining of this dysphagia, so you have to check these things also, candidiasis infection, and any difficulty in chewing, like sometimes the patient is having xerostomia, dry mouth present, the patient is not able to chew properly. So you have to check whether there is any xerostomia or dry mouth, anorexia presence, and unpleasant smell, medication history. Along with that, you have to check the medication history and the treatment history, because most of the medications which we have used in palliative care can cause dry mouth. Okay, so we have to check whether there is any that kind of things, and treatment history also. After chemotherapy and radiotherapy, the patients will get a lot of problems like stomatitis, excessive salivation. These kind of things will be there. You have to check for that also. Coming to the management part, you have to we in the within the hospital we use different kind of solutions. But in palliative care, we suggest sodium chloride, homemade saline for oral care. Water is the best agent for giving mouth care, but most of the patients are bedbound. So you better you use sodium chloride solution like homemade saline. You have to teach the patient about how to make homemade saline or soda bicarbs solution. Okay, so you can take 500 ml of water. For making homemade saline, you can take 500 ml of water, add 1 teaspoon of common salt and boil it, cool it. After that, they can use that solution for oral care. And if the patient is having that unpleasant smell is there, like infection there, then you can use soda bicarb solution. Again, you can take 500 ml of water and add 1/4 teaspoon of baking soda. The same process, boil it, cool it, and keep it covered until needed. So you can use after cool, then you can use that water for oral care. So coming to the procedure part, the patient, just imagine a paraplegic patient. They are able to brush their teeth, but they are not able to take all the articles nearby. So that time the patient need an assistance. We all know that. So within the when they go back, you have to empower the patient and the caregivers about the same, because when they go back to their home, the caregiver will take care of everything, because the patient is not do anything about their self, because that time the muscle wasting will be there. If possible, if they are able to do it, you have to encourage the patient to do it their own. You have to assemble all the articles nearby and empower them properly. And here also, always you have to, as we all do like this, only explain the procedure. Always you have to explain the procedure to the patient. You have to provide a privacy, provide semi-Fowler's position or Fowler's position to the patient. Place a towel under the chin and cover the bedding. You can able to prevent soiling of bed and their own clothes. And again, we all know that you can take a dentifrice on the brush and then you can pour water on it and you can give to the patient and encourage them to brush it well, and then you can encourage the patient to rinse his mouth frequently. Okay. So this is the common procedure for a able patient. So that time the caregivers will be give a guidance, or they can assemble all the articles nearby to the patient and support them. Okay. So coming to the terminally ill patient, just imagine an unconscious patient in the home, so not in the hospital. So within the hospital, we have a artery forceps and tongue depressor. For an unconscious patient, how they will give a oral care to the patient in their home. So they don't have an artery forceps. Okay, if you give an artery forceps, but they are not able to open the artery forceps well, because we all nurses, we train well, we have a such skill how to open the artery forceps, how to lock the artery forceps, but that caregivers doesn't know. Sometimes the caregivers are not able to learn properly because of this locking and unlocking system. And tongue depressor, we have a tongue depressor for opening the mouth, but in patient in the home, they don't have a the tongue depressor. How can they open the mouth? Just imagine. Can we tell the caregiver to insert the finger to the patient mouth and try to open? No. If you insert a finger in their unconscious patient, they start bite. So they will bite. Okay, they don't know how which thing is inside the mouth, or if anything goes into their mouth, so they will start biting. Okay, so you have to prevent that also. In home care settings, we can use spoon or ice cream sticks. Okay, and you can use 2 spoons, one spoon for opening mouth, one spoon for cleaning the mouth. I'll come to you later about how to clean, how to use a spoon for oral cavity care. And gauze piece, if they are having gauze piece, they can take. If they don't have gauze piece, they can take clean cloth, cotton cloth. Okay, and normal saline. So within the hospital, we have a bottle of normal saline. If they don't have a normal saline bottle, they can prepare homemade saline in their home. And small Macintosh, we have a rubber sheet. So if they are not have a Macintosh, they can use plastic sheets. Our purpose is to prevent that spoiling. Like we can able to prevent that damage, or prevent spoiling to the patient bed sheets and all. So we have to prevent. Okay, protect the sheets. You have to protect the sheets. And face towel. So always all the patients family have face towel, like any towel you can use. Clean water. We need a clean water for cleaning after cleaning with normal saline, and soap sticks also. So these are the articles needed for mouth care for an terminally ill patients. You can see the hospital settings and the home care settings. How what are the difference between the hospital settings and the home care settings? So you can see that picture here. You can take a spoon and the handle of the spoon wrapped with a gauze piece. Okay, as I mentioned earlier, we need 2 spoons. 1 spoon for opening the mouth and 1 spoon for cleaning the mouth. Okay, the same process. We have a video. I'll show you later how to wrap the gauze piece into the handle of the spoon and all, so you can see it. And coming to the procedure part, again, you have to explain the procedure to the patient, provide privacy, provide a small Macintosh with a face under the head. We can able to prevent the spoiling of bed sheets, and semi-fowler's position, and give semi-fowler's position and head turned towards one side, so that if there is any secretion there, that secretions will drool out, and otherwise it will cause aspiration. And use padded tongue blade open. So same thing. So instead of tongue depressor, you can use these kind of the spoon you wrapped with a gauze piece, and that part you can insert the mouth. That time the mouth will open. You can see that picture. Then after that, you can assess the oral cavity, whether there is any infections or bleeding or any inflammation, any things you can assess, any oral thrush, these kind of things you can assess. And after that, you can take another spoon and wrap it with the gauze piece and soak the gauze piece, that part, into the normal saline and squeeze out of excess water. Then you can clean the mouth. Okay. So this is the process. You have to wrap the spoon and you can soak the wrapped spoon part into the normal saline, squeeze out of excess water. This is very, very important. The caregivers doesn't know they should squeeze out of excess water. They usually soak that cotton piece into the water and directly put it in the mouth, so that what happened, the water inside the goes inside the throat and can cause aspiration. So these kind of things we can avoid. You have to provide a proper training to the patients. Before that, you have, instead of teaching, you have to demonstrate them how to clean the mouth. And clean the mouth, you can clean the lower chewing surface inside and outside, outer side, upper chewing surface inside and outside. So again, you can keep the wrapped spoon. First, you can keep the right side of the patient mouth, and so that the opposite side area is open. Then you can take that spoon. After cleaning, you can take the wrapped spoon from the right side of the mouth and keep it the left side of the mouth. Then the right side of the area is open. Then you can clean that area. Okay. So after that, you have to clean the oral cavity too. Okay. So always you have to clean the oral cavity with normal water, because the normal saline is an unpleasant taste. If you give that clean, if you provide a care after normal saline cleaning with normal water, definitely we can prevent the unpleasant taste from the mouth. After that, you have to lubricate the lips with any lubricated agents. So like these are the common lubricants: liquid paraffin, coconut oil, ghee oil, Vaseline. These are the common lubricants which we have used in palliative care. If they don't have a liquid paraffin or ghee oil or Vaseline, they can use coconut oil. So our aim is to lubricate the oral cavity, that lips and area. So that is why we encourage the patient to apply these kind of lubricating agents. So we have a small video on mouth oral cavity care for an unconscious patient in home care settings. I'll show you now, then I'll take that next part. Okay. I hope this will help you, that video. If you have any doubts, please note it in the notebook, and we will discuss it later about oral cavity care for an unconscious patient in home care settings. So let's share my screen. Okay. So next, we move on to the eye care part. So always you can see that two different eyes there. One is infected and the another one is non-infected eye. And the patient caregivers doesn't know which eye clean first and which eye cleans second. So we need to educate them well. Before touching the eye, they should wash their hands with soap and water, and after that they have to check which eye is for an unconscious patient. They have to check which eye is infected, so they have to clean the non-infected eye first and then go to the infected eye. Okay, so otherwise it will cross infection. Okay, it will that give a more infection to the, it is a chance to give a infection to the non-infected eyes too. Okay, so they need to give a proper care to the non-infected eye first and then move to the infected eye. Okay, when they take care of the eye, so they have to take a wet cotton ball and squeeze out of excess water and clean from the inner canthus to outer canthus. You can see that imagine from there, inner canthus to outer canthus. So these all things you have to tell them, and when they clean, they have to use one sock for one stalk. So that is also important. Otherwise, they will use the same sock for different stalks, because that can cause infections. And after that, they have to document well. Again, if the patient is in the hospital, we have to document it well. Coming to the ear and nose care, always you have to explain the procedure to the patients. You have to check any infections or any secretions inside the nostrils and all, especially the patients who are having nasogastric tube feeding. The caregivers not giving much attention to their nostrils. So you have to tell them if they have a any that infections or any crust formation into the nostrils, they can remove it with the help of a soft cotton cloths. And coming to the ear, especially behind the ear, if they are lying down in the side lying left lateral position or a right lateral position, there is a chance of accumulation of dust like behind the ear. So there is a chance of accumulation of dirt in that area. So that if you don't give a proper attention to that area, that can cause pressure ulcer. So that can things you have to check it. And also wax, if they have a wax in their ear, so they don't sometimes they may feel pain, and hearing problem will be there. So that time you have to properly assess, and you can refer the patient to the ENT surgeon. You don't use any sticks for removing the wax or any put any oil or anything. So you don't do like that. You have to educate the caregivers too. And coming to the hair care. So within the hospital, we all give hair care for a bedbound patients. We know how to take care of hair for a bedbound patients. But within when they go home, the caregiver doesn't know how to wash their hair with in the bed. So you have to teach them. Okay, they can, but they have to. We have a lot of we need lot of things for hair care, but within the home, uh, so they have a limitation with but if they have a small plastic sheets there, they can able to protect their bed sheets. And again they can take another plastic sheets like that, they can cover that hair part, and they can give a proper hair care to the patient. Okay, before giving hair care, they can insert a cotton ball into the ear, so that we can able to prevent water entry into the ear. And always they have to that cover the eyes too. So these are the things they have, you have to train them. If possible, you have to demonstrate them once before they go home. And coming to the nail care, so why I am mentioning these all things is We have a patients like that. We have a quadriplegic patient. Uh, so we he actually 2 months back I showed this video to that patient's family. They asked me how to take care of the actually she needs to wash their hair within the bed, but she's not able to get up. She is lying down all the times, but she needs a hair wash. But last 4 years she doesn't take any hair wash. She always, her mother that give a that bed bath to the patient, like a sponge bath to the patient, but not hair wash. I had shown this video to her, and her mother surprised, oh my god, since last 4 years we don't know how to these kind of things are there. So after that she learned from us, and then she start giving hair care to the her daughter. So this is very very important. You have to train like this, you have to demonstrate them and empower them. Coming to the nail care part, always you have to give a nail care along with the bed bath time. You have to check whether there is any nail or not. If they have a that long nails there, you have to cut short the nails. If you don't give a bed bath to the patients, you can take a that lukewarm water, and you can ask them to dip that long nail part into that water, so that after 5 minutes that nail will soft. So that part we can able to cut it easily, because the nails become soft only. Okay, after bath also we all know that after bathing our nails will be soft only. So this the same principles here. You can take you can soak the lukewarm soak the nail part into the lukewarm water, so the nail will become soft. And when we cut the nail long nails, you have to give a special attention to the skin also. If they have a diabetic, if you give some injury, if you while cutting the nails, if there any accident injury happen, there is a chance of infection. So that you have to keep it in mind. Coming to the bed bath part, these all things we know. This is very very important. If you give a bed bath to the patients, we can able to promote hygiene to the patients. Again, you can able to induce sleep and comfort level and sense of well-being, and these all things are the objectives of a bed bath. So here, coming to the procedure part, we all know that all how to give a bed bath. But when we come to the palliative care, you have to think about the patients from a patient side also. From the patient side, you have to check. You have to check with the patients whether the temperature, the temperature of the water is suitable for the patients or a comfortable for the patients. And also you have to tell the caregivers about only small area of the body should be exposed at the bath time. This is very very important. Usually they exposed all the area the same time, and they will start cleaning. So they will that kind of so because we have to give a dignity to the patients, we have to respect the patients. They are bedbound because of their illness. Otherwise they won't be able to, won't allowed to clean their body. They will do their bath own. But if the patient is bedbound, they need a, assistant. But we will give a dignified care to the patient. We have to expose the small area at a time. Which area you want to clean, that area only you have to expose. These things you have to educate them. And the next important part is cleaning is done from the cleanest area to the non-cleanest area. So we the upper part of the body, like face, upper hands and chest, that area we considered as the cleanest area. You have to clean that part first and then move on to the lowest clean area. So these all things you have to educate them. While we clean the patient's skin, you have to check the skin whether there is any color change or not. If there is any color change there, you have to give special attention on that area, and also you have to apply some moisturizing agent and give a small massage for that area, dependent areas, because that way we can able to improve the blood circulation and we can prevent bed sore prevention. Coming to the back care, for a bed-bound patients, we usually give a back care to the patients. So after bed bath, every 4 hours you have to 2 hours is good, but at least every 4 hours you have to give back care to the patients. Always you have to check the skin and apply some, after washing the skin, you have to pat the area by cotton cloth, not by rubbing. So if you rub the area, there is the chance of frictions. Friction is also another cause of pressure sore formations. Always you have to pat the area for drying. After that, you have to apply moisturizing cream, any moisturizing cream for that dependent area, so that we can able to improve the blood circulation. If the moisturizing agents are not available, you can use coconut oil. Okay. Coming to the exercise part, active and passive exercise is there. If they are able to do it, you can encourage the patient to do their own. But if they are not able to do it, you can encourage the caregivers to give a passive exercise. So if they are not do the exercise properly, that can cause lot of problems, like that pressure sore and constipation, wrist drop, that foot drop, these contractures, these muscle wasting. Okay, so if you give a proper exercise to the patients, definitely we can able to improve the muscles strength, and that way we can able to improve the blood circulation also. Okay, all joints need physiotherapy. If possible, you can encourage, they can do it their own. If they are not able to do it their own, you can encourage the caregivers. Coming to the catheterization part. So the catheterization, we all know that what is catheterization. We used to use Foley's catheter for catheterization. There are different kinds of catheters, types of catheters are there: indwelling catheterization and suprapubic catheterization, clean intermittent catheterization, and condom catheterization. So these are the type of catheterization which we know. So that the care will be different for every each types of catheterization. And you can see that picture. If the patient is having indwelling catheter, like you can you see that image, and suprapubic image catheterization also, you can see that image. Okay. Coming to the procedure, we all know that catheterization is one of the sterile procedure is done by a trained professionals. We usually you have to use smallest size possible. We in market we 14 French to 22 French are available. You can start using the smallest size as much as possible. So because if you use largest size like 18 French size catheter there, the patients may feel irritations and pain. Okay, you have to use 14 French catheter, and after that you have to lubricate well with the catheter, and before inflate the bulb, you have to inflate the bulb. Okay, so after insertion, you have to make sure whether the urine is coming out or not. that time you can okay, suspect, yeah, definitely the catheter is inside the bladder. Okay, after that you have to inflate. So how much water you will use for inflate? For inflating the bulb, we need to inflate the bulb. Okay, so how much water you will use for inflating the bulb? So please put your answers in the chat box. 10 ml?
Yes, ma'am, 10 ml.
30 ml.
30 ml? 10 cc? 20 to 30?
According to the catheter size we choose.
Okay. The catheter size says 30 to 50 ml.
15 to 20 ml.
15 to 20 ml. Okay. Let me see you all. Please switch on your video. Thank you. Thank you. Okay. Any other answers? So,
According to how long patient is in on the it is indwelling catheter, accordingly also the water changes.
according to the catheter says, right?
No,
Cut,
how long patient is on that indwelling catheter?
1 month. So if the patient is having indwelling catheter, you have to change every month, right?
Yeah.
So my
patient
question is, yeah.
Patient is using this indwelling catheter for many times, that will become loose. Then we need to use more water.
More water. Okay. Any other answers? So first we have to understand. Thank you for your answers. First we have to understand that why we inflating the bulb. So our aim is to return the catheter into the bladder. So if you apply, if you insert 10 ml into the that bulb, into the catheter, that bulb. So it will be look like this only. You can see that image. You can. Okay. So you can see that image. Here there is a bulb. This is a 10 ml capacity, 10 ml. Okay, this is 10 ml only. So if you use more than 10 ml, what happened? The bulb size will be increased. The bulb size will be increased, and that will touch the bladder mucosa, and the patients will develop bladder spasm. Okay, so you can imagine, yeah, I have seen many patients after inflating the bulb, so they will have some distress, some kind of facial expression, distress. Oh, you have to please remove this. I have pain. These kind of things will be there. So that is the problem because of the bladder spasm. Okay, if you inflate too much water, if you inflate the bulb with too much water, it will touch the bladder mucosa and develop bladder spasm. So that is why you can use 10 ml. Our aim is to retain the catheter into the bladder. So for that, you can use 10 ml. More than 10 ml is not recommended. Okay. The catheter says 30 to 50 ml. That is the capacity of the bulb. So 30 to up to 30 to 50 ml, you can inflate. That is the capacity. After that, that bulb will burst. Okay, so you can use 10 ml for inflating the bulb. And the another important things you have to keep it in mind is no need antibiotic prophylaxis for urinary catheter insertion. If they have a signs and symptoms of urinary tract infection, okay, then you can give some antibiotics. Okay, otherwise no need of antibiotics. Okay, so and the other thing is sometimes the urobags, when the urine coming out from the bladder within the tube and into the urobag, it look like a pus formation, that kind of cloudy urine will be there. So that time you might be suspect like that, the pus in the urine. So you don't give any antibiotics for that. You have to check patients whether they have any signs and symptoms of urinary tract infection. Then you can give some analgesics. You can take urine from the patient and send for culture and sensitivity test, and then you can give a course of antibiotics for that. And now we move on to the clean intermittent catheterization. This is the the second type of catheterization, clean intermittent catheterization. We use NELCAT. Okay, so 12 French NELCAT to the patient. Usually we use for a paraplegic patients. Paraplegic patients, they have their spinal cord injuries. At that time, the patient is having incontinence of urine will be there. We usually put a Foley's catheter for the same. But after that, for an young patients, usually they won't be able to continue with the, they are not willing to continue with the indwelling catheter, so that we can train the patient about self-intermittent catheterization. So the thing is, we have to train the bladder first. Okay, they have to have some capacity to hold the urine, or they have to give they can do this procedure every 4 hours. Okay, so they can use the NELCAT, and they can before that you can train the patient itself. Okay, they can themselves they can do it. Okay, you can train them, wash their hands with soap and water. After that, they can take a NELCAT and lubricate well with that NELCAT, and then they can insert the NELCAT into their urethra, through urethra into the bladder, so that the urine will come out, and that urine will they can collect it with the help of a small basin. Okay, so they after that they can discard it. Okay, so after inserting the NELCAT, after collecting the urine, they can remove the NELCAT, clean under running water, and keep it in a dry cleaned container. Okay, so we usually give 4 sets of the NELCAT to the patient, and every 4 hours they have to change the NELCAT. Okay. Here the advantages is we can able to improve the quality of life to the patients, because self-confidence and easy to use, they can use inexpensive, and reduce the risk of infection, and we can improve the sexual life also, because all that intermittent catheterization, they can do it every 4 hours, so that after the in between there is no catheter into their area. Okay, and the next one is quantum catheterization. If the patient is using clean intermittent catheterization during the sleeping time, in between they won't be able to get up. That time if they want, they can use quantum catheter for drain the urine. And the sometimes the patient is not willing to use indwelling catheter and intermittent catheterization, then you can suggest quantum catheter. Here some advantages and disadvantages are there. Here also less catheter associated urinary tract infection, because this is put in outside the urethra. It won't cause any infections. more comfortable than indwelling catheter. This is less movement restriction and non-invasive. Okay, we won't insert anything into the urinary system, into the bladder. And some disadvantages is leakage and skin irritation. Sometimes this kind of latex material is irritant to the skin and can cause allergic reactions, and sometimes it will fall. So these kind of disadvantages there, but more advantages is also there. And this is one case scenario. Can anyone please read it out? Anybody? Please read it out. Mamta?
The home care unit of the hospital made a visit and found that the patient was having pericatheter leak, so they changed the catheter. The next day the carer noticed that the pericatheter leak was still persisting. She called them again. They came and changed the catheter. Again the next day the same happened. Once again the catheter was changed. The catheter was changed 3 times, but the problems did not resolve.
Problem. Thank you. Thank you, Mamta. What could be the problem? The catheter was changed 3 times, but the problem did not solve. Answers.
Water was not enough.
10 ml is there. Any other answers?
Size of the catheter may be small for that patient.
Size of the catheter may be small for that patient. Okay. Any other answers? Think. Change the size of the catheter. Maybe the balloon partially whole. If the balloon is partially whole, what happened? The catheter will come out. Okay, here the pericatheter leak is the problem. Catheter is inside only. Pericatheter leak is the problem. Size of the catheter can be changed. Okay. Any other answers? Okay, thank you. So here you can imagine a patient with a catheter, indwelling catheter. And usually we use indwelling catheter for a bed-bound patient. For a bed-bound patient, one of the most common problem is constipation. Okay, so here is the answer is fecal impaction. If the patient is having fecal impaction there, usually the catheter, that fecal matter will press the catheter, compress the catheter, and that time through the catheter, the urine won't be able to come out. That time what happened? Bladder will give a compression, and then that time what happened? When the bladder contract, what happened? The urine will try to come out, but because of the fecal impaction, the fecal matters is the compressed into the catheter, that urine won't be able to come out. That time the urine will start leakage from the catheter in the side wall of the urethra. Okay, so if you give a proper management to the bowel part, because if the patient we have seen a really patients like this. So we usually after that the patients come to us and we treat the constipation part, and then the urine will flow smoothly, because fecal infection is the problem there. So always you have to train the patient about the fecal management. So this is a very, very important part. And the another problem is too much inflation of water. If you inflate the water, too much inflation of the bulb is there, again the bulb will touch the bladder mucosa, and the bladder will oversensitive. Their sensitivity can cause again pericatheter leak. And the other problem is infection. So these are the three major problems that patients will have a pericatheter leak. Coming to the bladder care, so every 3 weeks to 1 month, we have to change the catheter. If the patient is having indwelling catheter, Foley's catheter, the same thing, the silicone catheter is also available. If the patient, if they are using silicone catheter, no need to change every month. They can use they can change the catheter every 3 months, because of the silicone material. The silicone material are tissue friendly, less chance of occurring infections, but little bit expensive. If they are affordable, you can suggest the silicone catheter. If they are using silicone catheter, they can change it every 3 months. If they are using latex catheter like this Foley's catheter, they have to change it every month. And provide perineal care every day. So if they are able to wash their private part, they can wash with soap and water from the umbilicus to the mid-thigh. Okay, and so empty the bag. You have to tell them to empty the bag every at 3/4 of full, and intake of fluid. So here this is one of the foreign body inside the bladder. So there is a chance of getting urinary tract infection. So you have to educate the patient to take a water intake. So if they take proper water intake, so we can able to prevent urinary tract infection. So perineal care, bowel management, and water intake, these are the major parts of preventing urinary tract infection. Okay, and observe the urine. You have to tell them to observe the urine color and all. If they have a color change there, they have to let us know. But you have to check. If they give some kind of information, you have to check whether there is any signs and symptoms of urinary tract infection. Then only you can give some antibiotics for that part. And encourage the patient for daily bowel movement. So if they don't give proper attention to the bowel part, again fecal infection will be there, and after that spurious diarrhea will be there. Okay, if after a period of constipation, because of the bacterial bacteria in the intestine, and that will connect with the fecal matters, and then that because of that the fecal matter will liquefy it and leak through the side wall of the intestine and present it as a diarrhea. That is spurious diarrhea. Okay, so if the patient says like since last 2 days this diarrhea is there, then you have to check whether their bowel movement is that satisfied or not, how many times that bowel movement happened, that kind of things you have to take it, and then you can decide. You have to do a PRE and find whether there is any fecal infection or there. So if there is a fecal infection there, you have to give a proper management for that. Coming to the perineal care, here also you have to tell the patient about clean from the cleanest area to the less cleanest area. This is very, very important. You have to tell the caregivers, and after that urination and defecation, they have to wash their hands with soap and water. Coming to the bowel care for a bed-bound patient, as I mentioned earlier, due to lack of exercise, privacy, reduced food intake, and some of the medications can cause constipation, especially morphine. So morphine is one of the common cause of developing constipation. So these kind of things you have to assess it and educate the patient well. And if the patient is able to pass motion, you have to encourage the patient and give a adequate time to the patient, because in between you can, if you enter the room, they won't be able to pass, and less confident, they will be afraid of anybody coming to the room. So that kind of anxiety will be there. That time the patients won't be able to pass their motion freely. So give an adequate time to move their bowels, and patients should be encouraged to take high fiber diet, and you have to encourage them to take adequate water. So if they are able to, and encourage a regular exercise. So you can use bed pans. Always you have to think about that. If they are able to provide that kind of facility. So usually within the community settings, if they are not able to pass their motions within the bed, because if you give a bedpan to the patient, they won't be able to. But if you give a commode chair to the patients, they are able to pass their stool. But if they are not affordable, they won't buy it. These kind of things you have to check it, whether they are able to afford these kind of things. Otherwise, you have to make some kind of arrangement for that. As I mentioned earlier, spurious diarrhea. So if they have these kind, if the patient is having these kind of complaints, you have to take a proper history of the bowel management, and make sure that there is any fecal infection or spurious diarrhea. Then you can do a parectal examination and manual removal, and high sodium phosphate enema is the management of the spurious diarrhea management. You can insert a suction catheter into the rectum through the anus, and you can push two sodium phosphate enema at the time, so that sodium phosphate enema will goes up, and from that part the bowel will start move. Okay, so we can improve the bowel motility, so that the patients will pass motion. So we have a small video on catheter care. I'll show you later. Before that, I'll take another part on nasogastric tube feeding. After that, I'll show you a video. So here the last part is nasogastric tube feeding. Here we all know that what is a nasogastric tube, and what is how we can give a nasogastric tube feeding and all. But the caregiver doesn't know how to give a nasogastric tube feed. So you have to demonstrate well, train well. So these are the important points they have to keep it in mind while they give a nasogastric tube feed. Okay. So always they have to give semi-fowler's position before feeding. Okay. So let me ask one question. Why the patient, if you feed the patient in recommend position, like supine position, the patients will get aspirated. What is the cause of aspiration? If you feed the patient in recommended position, or you can use supine position, the patients will have an aspiration. What is the cause of aspiration? feeding may reach to lungs. How? The tube is inside the stomach only. What happened?
Backflow.
Backflow. Okay. For a normal person, you also take these kind of foods. Why you don't? You also have a backflow. Why you won't get aspiration? Why these patients get aspiration?
Because they are not able to swallow.
Why they are not able to swallow? They can able to swallow it. They can able to swallow it, but if they have any problem like any tumors or any before surgery, that time we will put a nasogastric tube. Okay, or if the patient is in unconscious, we will put a nasogastric tube. Okay. My question is, why these kind of patients will get aspiration? The nasogastric tube patients will get aspiration. Okay. Here, what you have to understand is, if you insert a nasogastric tube, what happened? If you insert a nasogastric tube through the nose into the stomach, we have a gastroesophageal sphincter. All persons all patients have a gastroesophageal sphincter. If you insert a nasogastric tube into the stomach, what happened? The gastroesophageal sphincter is always opened. Okay, so if you take anything in your mouth, once they enter into the stomach, the gastroesophageal sphincter will close. If you regurgitate, the gastroesophageal sphincter will tightly close and they won't allow food goes up. Okay, food is not able to come out from the gastroesophageal sphincter. If you insert a tube into that area, what happened? The gastroesophageal sphincter is always opened. Okay, so that is why the patients who is having nasogastric tube feed, the more chance to get aspiration pneumonia. Okay, so that is why we usually said like always give a feed with a Fowler's position or a semi-Fowler's position, and also you can keep the same position at least 30 minutes after feeding. Okay, so usually what happens after feeding, they will give the same position. So most of the bedbound patients can have these kind of complication, aspiration pneumonia. So if you give a proper education to the caregivers, these kind of complications, we can prevent it. Okay, here, so you can always, you have to aspirate and check whether the tube is inside the stomach or not. And you have to give at a time 20 ml feed and 50 ml water. More than 250 ml is not recommended. If you give more 250 ml, again, there is a chance of aspiration pneumonia. Okay, so for the sometimes less absorption will be there. Again, this can cause aspiration. Again, you will feed again and every 2 hours, 250, 250, 250. Likewise, you can check. Sometimes 100 ml absorption will be there. Again, remaining 150 ml is there. If you don't aspirate well, then again you will give 250 ml. Again, there is 350 ml total. So these 400 ml total. So these kind of overload will be there. So these kind of things you have to avoid it. So I will show you a video now. Then I'll take few questions. Questions? Anybody? So if you don't have questions, we can move on to the case presentation. Shanti Mary madam is waiting. Yes, Mamta, do you have
That
questions?
Yes, ma'am. In that video, she used soap for cleaning panic, but we always use betadine. So that's
Yeah.
okay. Or
Yeah, so you can use betadine, but within the hospital it is that is possible. Betadine, but if you use betadine, you can use diluted betadine. So concentrated one is not recommended. You can dilute betadine with normal saline, then you can use it. But in home care settings, we can't suggest betadine. If they are not affordable, they won't be able to buy it. They can use soap and water for cleaning. So for a trained persons, we sometimes they don't have any sterile that gloves is there. If they don't have a sterile gloves, they can use their own hands. They can clean under running water with soap and water. Make sure that their hands is clean. But for a from the nursing professionals, we used to show is as a that sterile procedure. No catheter, we have to touch the catheter part that goes inside the urethra. That there is a cause of infection too. So if we that make this kind of video, we won't we won't show that video without gloves. So that is why we use gloves for making this video. Uh, any other questions?
Ma'am, can we use Sablon solution
For what?
for cleaning?
Savlon solution is not recommended now.
Okay.
If you want, you can use betadine, diluted betadine, Savlon,
Okay, ma'am.
or you can use normal water with soap and water. If you are, if the patient is not a bed bound, if they are able to clean, they can use the soap and water. For a bed bound patient, that is not possible. Then you can use these kind of things. So our aim is to make that area clean. If you don't give a perineal care to the patients will get urinary tract infection. So that is why we encourage them to give a proper perineal care. Okay. So we can move on to the case presentation part. Shanti Mary ma'am will be presenting a patient story today. So, ma'am, over to you.
Yes, thank you, madam. Good evening to all.
We can hear you, ma'am.
Okay. Today I'm going to present the case presentation about the bed sore. The patient age is 75 years, male patient, and the diagnosis type 2 diabetic mellitus, hypertension, grade 4 bed sore in sacral region, encephalopathy, and comatose. Presenting complaints, recent UTI, deep bed sore over sacral region, stiffness of the body, unconscious, constipation for 3 days. History of illness. Mr. Badresh is a case of old CVA. He had history of fever 1 year back. He was admitted to the hospital, given an encephalopathy diagnosis, and he went into coma and treated for 15 days, and then he was discharged. Then onwards, he developed stiffness of the body and he remained in coma. He also developed a bed sore at sacral region, which was at stage 4. So at the time of admission, he came in this condition. On examination, patient was unconscious, GC poor, temperature normal, pulse rate 104 per minute, respiration 20 per minute, BP 140 by 90 mm of Hg, SpO2 98%, Foley's catheter and Ryle's tube in situ. And pressure sore stage 4, large and deep, foul smelling, exudates present, irregular in shape. Treatment and significant investigations. Treatment, sponge bath, alpha bed, debridement done, change of position second hourly, Ryle's tube feeding second hourly, and high protein diet. The investigations, RBS was 305 mg per dl, sodium 147, potassium 3.5, chloride 123, serum creatinine 1.5, and HB was 11 grams. Debridement procedure done. Psychological aspects, psychosocial aspects. 75-year-old married man residing with his wife and 3 sons. All 3 sons are married and raising families. After his wife passed away, he had fever. He earned a pension each month, and his 3 sons will take turns caring for them. First son drives an auto, and second son works as a hospital attendant, and third son is a daily wager. He is a Hindu. The 3 sons are trying their best to recover in the hopes that their prayers would bring them relief from pain. His sons and their families find it challenging to care for him on a regular basis, changing his position every 2 hours to give him a sponge bath, bandage his wound, and administer timely medication. The medication he was getting, injection Monosef IV BD, injection Amikacin 500 mg IV BD, tab pan for 40 mg before breakfast through Ryle's tube, tab Metrogyl 400 mg TID, tab Tramadol BD, tab Syndopa plus BD, tab Shelcal OD, tab Aptineuron OD, tab Glimistar M2 BD, and daily dressing with a Debridase ointment and Metrogyl solution, and physiotherapy. The main concerns are to maintain the hygiene conditions, to provide proper nutrition, to do sterile dressing, to give mobilization and change of position, to administer timely medication. After a month, the pressure sore condition is such. The summary, he is a 75-year-old bedridden man who has a grade 4 bed sore over his sacral area. He is on a Ryle's tube and has a Foley's catheter in situ. Hypertension and blood sugar are controlled. Mobilization relieves body stiffness, slowly healing bed sore. The discussion points. What are the problems faced by their families? How can we empower the family members? How can we support the patient and family members? Thank you very much.
Thank you, ma'am, for the wonderful presentation. Anybody need any more clarification regarding this patient story? You can ask, otherwise we can move on to the discussion points. I hope this presentation is clear to everyone. Anybody need any more clarification? No. We will discuss. Ma'am, so I would like to know what is the condition of the patient right now? Is he alive?
At present, he is at home,
Okay,
but his condition is same, madam.
same. Okay, thank
Yeah.
you. Thank you for the update.
Thank you.
Okay, so here, ma'am was presented a 75-year-old man, is a CVA, developed CVA and coma. He is a bedbound patient, is having stage stage 4 pressure ulcer, and he is having Foley's catheter and nasogas tube feeding. And so lot of problems. He has 3 sons, and they all will to take care of this person. They are trying to give a proper care to their father. So here we need to discuss what are the extra points we need to tell to Shanti ma'am for take care of this patient. Any other suggestions? Any points? Are you there? Okay, very good. Any suggestions? Okay, Mamta said he's a bedridden patient, so we need to give a oral care and nail care also. Okay, very good. Shadi ma'am, and one more thing I would like to know, who is the primary caregiver?
Yes, ma'am, because they have 3 sons.
Okay,
They actually each month, each one son will take care.
oh, okay,
So
oh,
he will be shifting.
okay,
So that is the way they have arranged.
okay, very good. So here we need to train 3 sons and their family, because
Yes, ma'am.
every month the place of care, the this change, no, different persons, and we have to give a proper training to those families. And how we can give care to this kind of families?
Actually, the second son brought him to the hospital
Okay,
because he was like so much deteriorating, and also wound is becoming more and foul smelling. They were not able to manage at home.
okay,
So in his time, he kept for 1 month.
okay.
Then again, next month is third son duty, and he
Okay.
was also working in the hospital like a attender. So he
Okay.
said that he can take care, saying that he took the patient home and went.
Okay.
But as long as they were here, we taught him and his wife also regarding oral feeding and oral care feeding, and also this giving sponge, taking care of the Foley's catheter, and cleaning the wound and positioning of the patient. All
Okay.
those things we were doing, madam.
Okay. Very good. Very good. Okay. Happy to hear that news. You have trained well to the caregivers how to take care of their father-in-laws and father. So that is good news. So here we have to respect the caregivers also, because they have to uh, do lot of things into their family. Along with that, they have to take care of the bedbound patients. So we have to give a respect to the caregivers too. We have to, if possible, you have to listen from the patient's family sides too, because they will be in distress. Nobody is there to hear their problems. Now, always the neighbors and relatives come and blame them. Why you're take care of the my father, or my brother properly, these kind of things. Sometimes only one day was happened like that. Sometimes if they don't yeah, if they are not able to change the sheets that day, that time the relatives will come. So that time they will start blame. So that will be affecting the patient family a lot. So these kind of things you have to give a, attention to, because whenever you have a meet these kind of patients family, you have to listen the patient's family's worries too. So just you can listen, you can ask a few questions. How we are you are doing these kind of things, are you able to do it? Do you have any problems? Anything? Do you eat properly? Do you have sleep? These kind of things. This is for caregivers. Okay, so we always focused to the patient's part, not able to much care to the caregivers part. Always you have to think about the patient's family, the caregivers part also. This is very, very important here. This is a blessed man, because three sons are happy to care that that father. So this is very is one of the good news for hearing from your side, because most of the place one son will be happy to the care that father, but one son is not willing to take care of his father. These kind of controversy will be there, but here three sons are happy to take it there, take him there, take them their own home, and give a proper care to the patients. So this is it's a very inspiring story. Uh, anything you want to suggest? Anybody wants to add anything? So again, as I mentioned earlier, this patient is having a Foley's catheter and the nasogastric tube feeding. Always we have to try to prevent aspiration pneumonia. You have to give a proper training to the caregivers, how to feed the patients, how to give a position to the patients after feeding also. They have to keep the position like that. And for Foley's catheter bladder care, they have to prevent urinary tract infection and fecal infection. So the immobility is there. This patient is bedbound, so there is a chance of constipation. So if there is a fecal infection there, again urinary tract infection. These kind of things they have to look into. So these kind of things, if you are able to see it, you can just give a proper instructions to the patients and the family. The patient is, of course, the patient is not able to do it, but you have to train the caregivers too. So any other points? Mehboob ma'am, anything you want to add? We can't hear you, ma'am. No, we can't hear you. Yes, now we can hear you. No, your sound is not coming. like that headset. Can you remove the headset and try to speak?
Can you hear me, ma'am?
Yes, yes. Now we can hear you.
Yeah, it's very good that all three sons are interested in the patient's care. And one more good thing is that one of them is attendant, caregiver. So, it is added point to the patient. And plus, instead of changing in turn the care to the patient, we can counsel the all three sons and ask them to help economically to this main person who is taking care. So because of that, what happens? Constant one person taking care will be more giving him the quality care and the quality life.
Yeah, that's true, ma'am. Sometimes it may not be possible, but we can try once. Sometimes it may not work well. We have seen patient like this. If one son is willing to take care of that person, others will be able to take care of them. Gradually, their support system will comes down. Okay, so that one person's will finally the primary the caregiver is the person to take care of the patient. Okay, so if you give but the changing shifting is a problem to the patient always, because a bedbound patients, you can imagine, from one place to another place, there are many problems. But the thing is, if you give this kind of suggestion to the patients, initially they will all happy to, oh yes, yes, we will help, we will give some amount to the you will give proper the care to the family. So again, the caregiver, the primary caregiver will be distressing. Nobody is come and take care of there, no. So again, they will be in depression stage.
Okay.
So this is a good idea, but the thing is, patients will suffer because of the transfer and all. What about the patient side, ma'am? Is the patient is happy, or Shanti ma'am?
Actually, patient is unconscious.
Oh, unconscious. Oh,
And he already, because of Parkinsonism, other things, his body is all stiffened.
okay. Okay. Thank you. And we wind up. Time up.
Yeah, thank you very much, madam.
Thank you, ma'am.
So
Thank
much, ma'am.
you. Thank
Thank
you.
you. And today is our last lecture, ma'am.
Ma'am, can you repeat again?
Today is our last lecture, ma'am.
No. Next week, coming Friday, Saturday, end of life care session will be there. That is your last session.
Okay. Thank you, ma'am. Thank
One
you so
more
much.
session.
Thank you, ma'am. Nice,
Okay.
nice.
Thank
Nice
you. Thank you.
meeting you all. Thank you.
Thank you. Bye bye.
Bye. Bye.